Apathy is when the brain loses the drive to act. Not the desire to act, but the drive to act. This might look like sitting still when you have the ability to move, oftentimes mislabeled as laziness or depression, which apathy is neither of those. It's about brain circuitry. And unfortunately, not to add salt to that post-stroke wound, apathy is reported in 1 in 3 stroke survivors. So if you've ever wondered why you or a loved one just do not seem to care, this video is for you. Because in this video, we're going to go over what apathy actually is, what the research says about post-stroke apathy, how to identify it, and most importantly, what you can start doing today to rewire your brain to have more drive and more motivation to do the hard work that is absolutely necessary for post-stroke recovery. If you're new to this channel, I'm Tara. I'm a neurologic physical therapist with over 22 years of experience helping people with neurologic injuries restore their mobility and their independence. And I've taken everything I've learned in those 22 years and created our Rehab HQ membership program. Our membership program includes only the things that I think absolutely actually work to help you restore your mobility and your independence. But the most important part is it puts it all in your hands, giving you full ownership of your recovery. To learn more about our membership program and to sign up, you can visit rehab-hq.com, where you can learn more about our membership programs, but also you can schedule a discovery call to talk to someone in person about your goals and your limitations. They can help you to decide whether or not our program is right for you. But now, back to today's video, post-stroke apathy. And before we dive into how you rewire your brain to be more motivated and to have the drive to do the necessary work to restore your mobility, it's important that we clear up some confusion on what apathy is with a clear definition. Apathy is a loss of motivation and initiation caused by disruption in the brain's goal-directed networks, resulting in reduced drive, effort, and emotional engagement, even when physical ability and awareness remain intact. So again, as I mentioned at the beginning, apathy is diminished drive, but not diminished desire, which is where a lot of people that I work with, I think, have that internal battle, because I hear things like, oh, I know I should do this and I'm just not doing it. That's very, very common. So I want to be clear that the desire is still there. It's just that the drive is missing. Now, there's different levels of apathy. Generally speaking, not specific just to stroke. A more kind of severe form of apathy, a new term that I learned, is abulia. And then the most extreme form of apathy is akinetic mutism. For any of you nerds out there that want to look these terms up, an akinetic mutism is rare after stroke, but it's when there's no movement and no communication. And I think looking back on my 22 years, I can identify a lot of people that don't just have that apathy or that indifference, but probably fall into that abulia category where it's a little bit more severe and really impacting their ability to do the exercises, but more importantly, really impact their quality of life. So the way I kind of view it is that motivation or that drive to not just engage with your physical therapy activities, but engage in life for all humans is kind of on a dimmer switch. It's not either you have it or you don't have it, but there's varying degrees. So for some people, motivation is extremely high and it's turned all the way up. And for people who are on this apathy scale, there's different levels to how that dimmer switch, how much light is coming through or how dim that light is becoming to the point where there's no light coming out at all. Okay, so it's not an all or none. It's not either you have it or you don't have it. Everyone's on a spectrum, whether you've had a stroke or not. It's really important to understand, and I mentioned this at the beginning, that apathy and depression are not the same thing. And oftentimes, apathy gets misdiagnosed or misidentified as depression. But depression is hopelessness. More importantly, someone communicates that or expresses that hopelessness externally. It's oftentimes associated with sadness and a depressed mood. Apathy is not those things. You will not see some of those characteristic outward expressions of hopelessness and sadness. And in fact, most times, people with apathy are much more emotionally blunted, which we'll get into here shortly. But in my experience, someone who's depressed knows they're depressed and they will tell you they're depressed, or they will tell you they feel hopeless. That is not the case when someone has apathy. The downside is, in both cases, some of the behaviors are similar. There is a lack of motivation to do hard things, not really just hard things, but to do a lot of things, engage in social situations, and both depression and apathy impacts your ability just to want to engage with life. Now, what does the research say about post-stroke apathy? Well, as I mentioned earlier, the data suggests that it occurs in probably 1 in 3 people that have had a stroke, primarily those with strokes in the right hemisphere. Now, the literature is mixed on whether it's the right hemisphere, more associated with the right hemisphere or the left hemisphere. I don't see anyone that's 100% confident that it's associated with one hemisphere over the other, but I will just tell you, in my experience, it is much more common, much more, like off the charts more common with someone who has had stroke in the right hemisphere. And unfortunately, my experience and what the data suggests is that people that report post-stroke apathy have a slower recovery and poorer outcomes compared to people that don't have post-stroke apathy. But the good news is, or the hope, I think, is that the reason those outcomes are worse is because no one addresses it, like no one in the healthcare system. I've never even heard the word abulia ever in my 22 years. And for most of my career, until I left the traditional system, I was on interdisciplinary teams where we met weekly with neuropsychologists, social workers who are there to highlight maybe some of the potential barriers to physical recovery. They do other things as well. And this is the first time that I've heard that term. So I know that not only is it underreported, which is captured in the data, they do mention that, because there's something else that people that have had strokes on the right side of their brain have many times, and it's anosognosia, which means lack of awareness completely of their limitations, to the point where people that I know that have had strokes that have this anosognosia will deny and fight me until the end of time that their balance is not impaired and they are perfectly fine to be walking, and they look at me like I've got 3 heads when I tell them that they're not safe to walk. So that complicates things a little bit in as how much this is reported, but then also how much it's treated, which I don't think it's treated at all, to be honest. Everyone's on an antidepressant. I will just say that. Everyone is on an antidepressant that has had a stroke. I don't think I'm being hyperbolic. And again, this is just from memory, but I cannot think of a patient that I have treated in the first year after their stroke that was not on an antidepressant, because it's given to them when they're in the hospital. And we'll go into some of the pharmaceuticals a little bit, but it's just shocking to me because I don't think all of those people have depression. So we're not treating it appropriately. So back to what I was saying, I know I got off on a little bit of a tangent, but the evidence that suggests there's poor outcomes, in my opinion, has a lot to do with the fact that it's not being identified and it's not being treated appropriately. And that's what I hope to accomplish in this video. So you're in the right place. So I hope that you have hope that if you have post-stroke apathy, this is something that you can address and rewire that brain. But now, as far as the research, They think, and I agree with this, that there are a few types of strokes where this post-stroke apathy might be more common. Strokes in the frontal lobe, primarily the right anterior medial aspect, which lines up with what I see. This area of the brain gets its blood supply from the middle cerebral artery, a branch off of the middle cerebral artery. And the middle cerebral artery is where most blood clots occur. And the explanation that makes the most sense to me is it's just physics. Once that artery enters the brain, it immediately does like a turn. So there's almost like it's, if you think of blood vessels like a garden hose, there's kind of like an immediate bend in that garden hose. So if a clot's going to get dislodged or anything's going to happen, it's probably going to be where that bend occurs. So that makes sense to me. But right frontal lobe for sure, based on what the evidence says and also based on my experience. The basal ganglia and internal capsule. Also, another area of the brain where if you have damage to this area of the brain, you might be someone who has this post-stroke apathy is the basal ganglia and internal capsule. Now, the reason I'm mentioning these areas of the brain is because most of you have access to your MRI reports, and these will be the areas that you will see on your MRI report. And the reason why people that have strokes in the basal ganglia and the internal capsule, one is this is where dopamine is made, and dopamine is a neurotransmitter. Neurotransmitters are just little molecules that allow neurons to communicate with each other. They're deployed from one neuron and they go to the next neuron and they either upregulate that neuron or they downregulate that neuron. So when you're talking about a neural network, neurotransmitters are what communicate a signal along neurons. Dopamine is a neurotransmitter that gives us drive and motivation, or it is the neurotransmitter that allows that communication to occur between neurons in the areas of the brain that are responsible for drive. So that would make sense to me. And that is what the research shows. So strokes in the basal ganglia or internal capsule, what this will usually look like, according to the scientists, is someone is like slow to respond or slow to react. So again, as I mentioned at the beginning, it could appear like someone doesn't care because they're not reacting appropriately. But remember, this is a brain circuitry issue. That is why they're not reacting in a way that you would think is appropriate for the situation. And then the thalamus in the right hemisphere is also an area that's associated with post-stroke apathy. And the reason for this is the thalamus is kind of like intermediary or a relay point between the frontal lobe, which the frontal lobe is kind of like the starter engine for a lot of things. Thoughts, emotions, behaviors, and the thalamus is intermediary between the frontal lobe, what initiates that behavior, gets you thinking about that behavior, to the emotional areas of the brain, have to go through the thalamus. So that also makes sense to me as to why someone that has had a stroke in their thalamus, again, on the right side, I want to keep reiterating that because one thing I hear often, across the board, is, oh, I was like this before my stroke. Well, maybe, but were you like this to the degree that you can now not be safe or you can't be left alone because you won't do anything? There are varying degrees, but it is extremely common. People will tell me I had ADHD before my stroke, and so this is just how I was. But it's really important to identify, is this post-stroke apathy? Not to feel bad, but so that you can start taking action and implementing the necessary steps to maintain your motivation and drive to do the things you need to do to restore your mobility after a stroke. So people that have had strokes in their thalamus, they might have the idea or the thought or the desire to want to do something, but because there's a little interruption before it gets to that emotional area of the brain, they're just kind of indifferent. Their mood seems pretty blunted, and I can attest to this. Their affect might be a little bit flat when it comes to their excitement over doing their exercises or really doing anything. It's just kind of like, yeah, it's okay. Yesterday was okay. My week was okay. My exercises are going okay. Just kind of like an indifference. That would be some of the characteristics of someone who has a stroke in their thalamus that might be dealing with this post-stroke apathy. They have the thought, they have the desire, but before it gets to that emotional area of the brain, before that desire or that signal can get to the emotional area of the brain, there's an interruption. And then the other area of the brain that is very involved, and this is important just if any of you have aging relatives, family members, parents, grandparents, it are the white matter pathways. Now, why is this important? The post-stroke apathy would be associated with strokes in the white matter. Most of the time, these are mini strokes. In other words, someone's not having this like major event where one day they're walking and one day they're paralyzed on half of their body and they're going to the hospital and they're getting a diagnosis. I think this gets missed a lot, but when there is damage to those white matter pathways, someone will become more apathetic over time. So you will see a gradual decline in motivation. And I do think that this gets missed a lot. So if you have diabetes, or if you have poor metabolic health, which is really just how your body breaks down and utilizes energy, if you have heart disease, if you have congestive heart failure, remember, strokes are a plumbing issue. Although we think of them as a neurologic issue, that damage is occurring because there is a problem with the plumbing, blood being able to get to those areas of the brain. And I think this is a lot more common than is being reported because I think it gets missed a lot. Most people will chalk it up to, oh, the person's just aging, they're slowing down, they just feel more comfortable at home now. Or one that I hear a lot, and I probably am guilty of this with some of my family members, is they just don't want to go out and socialize because their hearing's getting bad and they don't like having conversations in these environments where there's a lot of noise. Now, granted, hearing aids are better now, and there's a lot of things that have changed since I've experienced this with my own family members, in particular my grandparents, but it's easy to chalk it up to like this is just a normal part of the aging process when it could be something going on neurologically because of a plumbing issue. And people that have strokes in this area, the way this might look clinically is just a gradual loss in initiation. And according to the writers of the paper that I will link in the description below, it's often misdiagnosed as depression. And then generally speaking, the only reason I mention this term is because I've seen it in MRI reports. If it says like right territory, MCA infarct, MCA middle cerebral area, that's just a general term. But if it says that that area has been affected and it's in the right hemisphere and you lack drive and motivation, even though you have the ability to do things, all the things we've already talked about, then you might be dealing with post-stroke apathy. So again, the only reason I throw these terms out there is most of you have access to your MRI reports. And this is really, really common. The only way I can describe it is they're really like emotionally blunted. Again, I know I've used that term a couple of times, but they're really disconnected from their limitations. Meaning that if you really worked, they could pull it out. But many times I will just ask someone, what are your goals? What do you want to work on? What do you think you're having difficulty with? And they're like, I don't have any goals. I'm fine. It's like it's very hard to get someone to give me a goal. And so then when I try and dig deeper and say, well, what are you struggling with in your day-to-day life? They cannot come up with anything. And on the flip side, when they're making progress, they're also completely disconnected with that. They cannot identify anything. Like, let's say someone was fully dependent on a caregiver to transfer, and this is a real situation, a real story, fully dependent, and now they're doing it on their own. And if I ask them, like, is anything improved? Are you seeing any progress at home? It's just kind of like, no, everything's about the same. Like they can't identify that. They can't, it's multiple levels, but it's like they can't identify that their caregiver was helping them. And then they also can't identify that they are now not getting help. So it's very strange. That's the best way I can describe what I see. But I think that's what the literature means when it says they're disconnected with their progress or they're disconnected with their limitations. That's what I think it looks like. All the evidence or all literature you have to take with a grain of salt because this is a very complicated issue. First, a caregiver has to recognize it in most cases and report it to a doctor or express something like family member just doesn't have drive or motivation. And then on the flip side, that healthcare provider, doctor, physical therapist, neuropsychologist, has to have the awareness to either do further testing or ask more questions to get more information to differentiate, is this depression or is this apathy, post-stroke apathy? And a lot of times that's missing. So knowing the exact number of how many people are dealing with this is going to be limited, or is a limitation of most of the data or literature that's out there. So now that we got all of that out of the way, just because you've had an area of the brain that I just mentioned that was impacted doesn't necessarily mean that you have this post-stroke apathy. So now we're going to go into what are some of the characteristics. So what I did was, with the help of ChatGPT, is pull together all the assessments that clinicians use to identify someone with apathy and kind of come up with the most common themes on these assessment scales that might indicate someone has apathy. So some of the characteristics that would be pulled out from some of these assessment scales is that you need constant prompting to start tasks. You can act when told, but rarely on your own. You feel emotionally flat. You know what to do, but can't get yourself to start. And you lose interest halfway through familiar tasks. Those would be the most common themes in the assessment measures that a clinician could use to assess that. But I wanted to go a step further and make it easier for you to remember. So again, with the help of ChatGPT, we came up with a little acronym, and it's motivate. So motivate, M is for maintaining effort or attention to a difficult task. Maintain. The inability to maintain effort or attention on a difficult task. O is opting out. You just want to opt out on social engagements. You really don't want to be around other people. So you opt out on things that maybe once gave you joy, primarily social engagements. T stands for tone. So tone is flat, they're emotionally blunted or muted. Humor, frustration, success rarely registers, whether in their facial expressions or their voice quality, volume, cadence. It's just all flat. I is initiation, the inability to initiate, needing prompts to initiate anything. V is values, things that used to give their life meaning and purpose, they just don't really care about. So maybe they used to enjoy hobbies, or they enjoyed music, or they enjoyed bird watching or whatever. They just don't have any interest in this. And I see that quite a bit because I'm often asking people about their values and about hobbies so that we can attach some of their therapy to things that they used to enjoy doing, and they really can't come up with anything. So that's the V. A is action requires prompts. You need to get them to act or do anything, they have to be prompted. The next T is time. So the symptoms usually last for more than 4 weeks. So again, I told you this is all on a scale. Our motivation waxes and wanes for all of us, whether you've had a stroke or not. So it's if these behaviors last for more than 4 weeks. And E is emotion, no emotion. That's the big differentiator between depression and apathy. There is no emotion, no positive emotion, no negative emotion, just flat. So again, motivate. M, maintain. They opt out on things. Tone is flat. Initiation is gone. Values seem non-existent. Action requires prompts. Time, it should last more than 4 weeks, and they're emotionally blunted. All right, so now that we've identified it, what are some things that you can do to help treat it or manage it or restore some of that motivation and drive? We have to talk about medication because Doctors love to medicate. And I will say there's ups and downs of medication, but as I've said in any video where I talk about pain or emotions, remember, for every medication, you are making a trade-off. There is no medication that you put into your body that you are not making a trade-off. So where do I think people need to start? Nutrition, sleep, movement, and mindfulness, my 4 pillars that I always talk about. Why mindfulness? Mindfulness is actually a practice in increasing your ability to attend to an activity, amongst other things. But that's one reason I do it, not as regularly as I should, but it is for that ability to learn how to, or to rewire your brain to be able to focus on something for a prolonged period of time without letting your brain get flooded with other thoughts or feelings. And so it's one step that can help to rewire that brain and to improve your focus, that M, that maintaining motivation or effort, maintaining effort onto a difficult task, mindfulness. But then also sleep. When we're sleep deprived, we know that our attention is low. So if you haven't had a sleep study, I talk about this quite frequently. Sleep disorders are extremely common after a stroke. You should probably have a sleep study done. Snoring is a classic sign that your sleep is being disrupted. And then if you're not getting good quality sleep, of course, your attention is going to be affected. Or flip that around, when you're getting good quality sleep, you could be leveraging a little bit more attention and motivation. Think about before you had your stroke. Definitely, we can focus a lot better when we've had good quality sleep. Nutrition, absolutely essential. I know I talk about this a lot, but if you're putting garbage in your body, your brain is not firing on all cylinders. And then movement. Movement gets endorphins going, and sometimes just taking action will give you the motivation. You overcome that hurdle of starting to be able to continue on with that activity. So daily movement, non-negotiable for most of the patients that I work with. We have to get on a plan. If you're completely sedentary, and some people where we start, some people that I work with, they're only out of bed for like 6 hours a day, some less than that. So there is no too low to start. You just got to start. How do you start increasing your time out of bed? And then how do you start increasing your movement during the day? That can absolutely help. So that's the foundation. That's step one. There's some evidence that RTMS, that's repetitive transcranial magnetic stimulation, has some potential benefit, but I wouldn't say there's robust data, and I wouldn't say that the outcomes of people that have had RTMS are staggering. But it exists, and the mechanism behind it definitely makes sense to me. You are stimulating areas of the brain. So mechanistically, that seems like the most promising intervention. Maybe they just need to dial in the protocol a little bit so that the outcomes are a little bit better. But definitely, there's enough data that that could be beneficial. As far as pharmaceuticals, and I'm not a doctor, this is just based on the evidence, dopaminergic drugs, so drugs that enhance dopamine in the brain, seem to be beneficial. And I have seen doctors that do prescribe that to some patients. Again, I'm not a doctor. Talk to your doctor, but I'm just giving you my experience of what I see when people bring me their medication list. So that being said, the other one on that list that I am seeing more frequently, but really I've been seeing this for years and years before it was even trendy, are amphetamines. Listen, that scares me. And every time I see that on someone's medication list that's had a stroke, I get a little bit nervous. Amphetamines are stimulants. So I understand the logic. I just don't know if I don't think, I'm not a doctor. I do not think that that's appropriate after a stroke, but I haven't had any patients that have had another stroke. And again, I don't get involved with that. I'm just telling you what I see on their medication list, but I would steer clear of the amphetamines. But just throwing that out there because they are used. Now, as far as behavioral interventions, which is the world that I live in, using timers to set a time frame on when an activity starts and when an activity ends, having like an end goal that's like 20 minutes max can sometimes be that like light or be that finish line that makes it easier for someone to say, okay, I can do this for 20 minutes. So I think timers work really well, checklists work really well, and keeping things simple. Maybe you just choose one therapy activity a day and you get consistent with that. And then after a month, maybe you think about adding a second one. Keep it super simple. Keep your rehab program, your daily rehab program, extremely simple, and use timers and checklists. There's something motivating just from someone who hasn't had a stroke, but just being a human, of checking things off of a checklist that can give you that little bit of extra dopamine, especially if you've had a stroke in your basal ganglia, that might be beneficial. And then this is for the caregivers. Be very strategic and intentional about how you provide prompts. It's very easy to revert to, they're just not trying, they're not being helpful, they don't care, because of what you see. But just be careful and be mindful that you're continually stepping back. I'm guilty of this too. Sometimes I get frustrated during a therapy session because I have that same emotional reaction with a patient occasionally. It's just a human response when someone's telling you that they want to do something and then they just seem like slow, or like it looks like they don't care from the outside. You really have to be cognizant that this is a brain issue. Try not to nag your family member into doing things. Just be very clear with your prompts, keep them simple, and know that repetition is just going to be par for the course. Meaning you're going to have to prompt someone maybe even several times to do the same activity to get dressed in the morning, just to get through daily activities. So be prepared for that and kind of have a plan and be able to step back and separate how you might be feeling emotionally and zoom out to what's actually going on with your family member and the complexities that are going on in their brain in that moment. They want to do it. They do. They want to do it. The areas of the brain that get them to take that action are just not engaging. And then as far as behavioral strategies, just celebrate the small wins. Always. Super, super important. Set realistic goals, but also celebrate little tiny successes throughout the process. And then the big one that I think everyone should do if you really want to take ownership of all those behavioral things that we just went through is just reframe it. Make sure you're continually reminding yourself that this is a brain issue. This is not a desire issue, and this is not a character flaw. This is literally something that's going on in your brain, and that you have the power to overcome that by just starting. Take action. Force yourself to do that thing that you don't want to do, and know that you need to set the expectations that you're most likely not going to want to engage and do the things that are hard and that you don't want to do. And so be aware of that. Be aware of what's going on in your brain and kind of find ways to just get started. Cannot stress that enough. Just start. Even if you only spend a minute on that activity, just start. And then don't beat yourself up when you fail. You may get halfway through an activity and then forget what you were doing, right? Or lose your attention to cleaning or whatever you were doing in that moment, getting dressed. You might put your shirt on and not put your pants on because you got bored and you moved on to the next thing. Just have a little bit of grace for yourself that those aren't failures. They're data points that can help you identify what areas in your day are most impacted by this and come up with strategies to overcome those. And again, most importantly is talk to your doctors and your rehab team. Don't listen to some random person on YouTube and start self-diagnosing. The point of this video is just to bring awareness to it, and hopefully give you a couple of suggestions that might help you, but really having the involvement of your entire rehab team is absolutely essential. I think a physiatrist is absolutely an important part of a rehab team. And then also, I think a neuropsychologist is also a very valuable person to have as part of your rehab team, making sure that they treat clinically and not just prescribe medications. And if they don't, that they can refer you to the right person to help you to treat the behavioral components of this post-stroke apathy. But I hope you guys found this video helpful. Don't forget, if you want to take full ownership of your rehab and you want to go a little bit deeper and really learn the things that are the most important that you should be doing in order to improve your mobility and your quality of life. All of those tools are part of our membership program. To learn more about our membership program, to sign up, or to schedule a discovery call, visit rehab-hq.com. I enjoyed spending time with you all today, and I'll see you in the next video. Have a good day.